Okay, if you're a nursing student, you know exactly what I'm talking about, right? That feeling of staring at a mountain of nutrition facts, just trying to cram it all in your brain before a big exam. It's a lot.
But what if I told you there's a better way? What if you didn't have to just memorize everything? What if you could actually understand the logic behind it so it all just clicks into place?
Well, that's exactly what we're going to do right now. We're going to build a super simple, logical framework. The goal? To turn all that painful memorization into real understanding so you can walk into that clinical setting feeling confident. All right, let's get started. Our logical journey begins right where all good nursing care does, with a solid assessment. I mean, this is the foundation for absolutely everything else.
So, what even is a nutritional assessment? Think of it like being a detective. Seriously, you're gathering all the clues, all the key pieces of information to build a really clear picture of your patient's nutritional status. It's the first step, and it's absolutely crucial before we can even think about what to do next.
And you know what? There's an easy way to remember the core parts of an assessment. Just think ABC. Super simple. A stands for anthropometry. And yeah, that's just a fancy word for body measurements. B is for biochemistry. We're talking lab values here. And C is for the patient's overall clinical condition. C, A, B, C. Easy, right? And so effective.
Okay, now let's zoom in on that B for biochemistry for a second. There are some huge red flags you have got to watch out for. These are what we call the indices of malnutrition. So if you see a patient's serum albumin dip below 4.0 or their body weight is under 80% of what it should be, those are massive warning signs. They need your attention like right away. These aren't just numbers to memorize for a test. They signal real serious risk for your patients. All right, so now we've got the how of assessment down. Let's talk about the who, because a patient's nutritional needs, they're not static. They change a lot as they go through life. You can almost picture it like a nutritional journey, right? For now, we're going to focus on 3 really critical stops. First, the crazy rapid growth of infancy, then the unique demands of pregnancy, and finally, the specific challenges that come with older adulthood. Each stage has its own playbook. So, starting with infancy, the big talk is always about feeding. Breast milk is, well, it's pretty amazing. It's packed with those vital fatty acids like DHA and ARA for brain development, and it's generally easier for the baby to digest. Now, formula is a great option too, of course, but a big part of our job is educating parents about the costs and, really importantly, how to prepare it carefully and correctly. Okay, let's jump ahead to maternal nutrition. And wow, look at this. The need for certain micronutrients just skyrockets during pregnancy. I mean, folate goes way up to help prevent birth defects. Iron needs a huge boost to support all that extra blood volume. These are not small tweaks, you guys. They are absolutely crucial for a healthy mom and a healthy baby. And then we get to our older adult patients. This is a whole different ballgame. We're looking at a natural loss of muscle mass, fat tending to deposit more around the abdomen, and on top of that, their bodies just don't absorb vitamins and minerals as well as they used to. That whole combination really ups their risk for things like type 2 diabetes and heart disease. Okay, we have assessed our patient, we've thought about where they are in their life. Now, what do we do with that information, especially when we're managing specific diseases? This is where nutrition stops being theory and becomes a powerful tool you can use. Let's kick things off with a big one, hypertension. High blood pressure. And the key word to remember here is consistently. We're not talking about a random spike because you're stressed. This is a constant high pressure that puts a really dangerous strain on the heart and blood vessels day in and day out. So how do we tackle it? Our game plan has 3 main parts. First, we need to educate our patient about the DASH diet. Second, and this one is so important, we have to teach them how to cut back on sodium. And third, we've got to encourage regular physical activity. As the nurse, you are the coach for these lifestyle changes. It's a huge part of your role. And when we say cut back on sodium, we need a specific target. So here's the number to lock into your brain for your patients and for your exams. 2,000 milligrams. 2,000 milligrams per day. That's the magic number, the upper limit we're aiming for. Okay, let's move on to something a little more complex. Chronic renal failure. Man, managing nutrition for these patients is such a delicate balancing act. On one hand, you have to prevent them from becoming malnourished. But at the same time, you're trying to control their lab values, their blood pressure, and their fluids. It's like walking a tightrope. Seriously.
And the diet plan isn't one size fits all. It actually changes depending on the type of dialysis. So you'll see that protein needs are pretty high for both. But the big difference is with potassium. For a patient on hemodialysis, potassium is much more restricted than it is for someone on peritoneal dialysis. Understanding why that is helps you give the right education to the right patient.
But what if a patient just can't eat, like at all? What if their GI tract is completely out of commission? Well, that's when we have to bring out the big guns, our final and most intensive intervention, which is parenteral nutrition. Parenteral nutrition, or PN for short, is basically intravenous feeding. We're bypassing the gut entirely, and it's only for really specific, really serious situations. We're talking about patients with severe trauma, major burns, or someone who's recovering from some really aggressive chemo. Okay, but listen up. Just as important as knowing when to use PN is knowing when not to. And the number one rule, the thing to always remember, is so simple. If the gut works, use it. Period. We do not use PN if GI feeding is an option, if the patient is super unstable, or if there's really no therapeutic goal. Your clinical judgment here is everything.
Whew, okay, that was a ton of information, I know. So let's do a quick fire round to lock in all that logic. We're going to boil this down to the absolute key takeaways.
First up, assessment and life cycles. If you only remember one thing, remember this. For assessment, it's your ABCs: anthropometry, biochemistry, clinical. And for life cycles, just know that nutritional needs are not static. They change big time, from infancy to pregnancy to old age. Next, clinical diets and PN. The takeaway? For cardiovascular disease, it's all about sodium control. For renal patients, you're restricting things like protein and potassium. And for parenteral nutrition, the logic is crystal clear. You only use it when the gut doesn't work. See? By focusing on this logical framework, you can get past just memorizing facts and really start to understand applied nutrition. Remember, this summary is based entirely on your course notes. Revise this once before exams.
Comment your next topic and subscribe MedX Lab.